Hello and welcome to the Montana State University College of Nursing's Center for Interdisciplinary Health Workforce Studies Spring Webinar Series focusing on the workforce serving frail older adults. We are pleased to have you joining us for today's webinar. My name is Christy Friedman and I am the Program Manager for the Center. One quick center announcement before we begin today's webinar. We recently released fourth quarter 2017 RN employment data showing a rise in employment in non-hospital settings, as well as a rise in employment across all age groups. Visit our website for a full look at the data. After today's presentation concludes, we will have 15 to 20 minutes for discussion and questions and answers. Please feel free to type any questions you have in the area designated for questions on your menu bar, and we will get to as many of your questions as we can. We're also recording the webinar today, and we'll have it posted to our website. We have posted all the previous webinars to our website as well as if you've missed any of them. And you can also find presentation slides for many of the webinars posted within the Video Library tab on the Center's website at healthworkforcestudies.com. Turning attention to today's webinar, I'd like to take a moment to have Peter Bierhaus, Center Director, introduce our speakers. Pete?
Hey, Christy. Thank you very much. I'm out here in Bozeman again, broadcasting. We've got cloudy skies. It's in the 50s. Spring now appears to have finally overtaken winter, even though it's got 15 inches of snow in the backyard. But the birds are pairing and the bears are coming out of hibernation, and we're beginning to get optimistic. So I do want to say a special thank you to Dr. Karen Donelan, who has helped the center organize this spring's webinar series. And so thank you very much, Karen, and we'll be hearing from you in a moment. But now I'd like to introduce our two panelists, or two webinar presenters. First is Dr. Dave Auerbach. Dave is a health economist and is currently the Director for Research and Cost Trends at the Massachusetts Health Policy Commission. His work has spanned a number of focus areas, including understanding employer markets for insurance, spending trends and cost drivers, primary care, and particularly the healthcare workforce. He is specialized in and is nationally recognized expert on the registered nursing workforce, including advanced practice nurses. Dave has co-authored and authored several dozen publications on a range of topics in the top journals in our field, including the New England Journal of Medicine, the Journal of American Medical Association, and Health Affairs, and numerous others. But Dave was also a senior policy researcher at RAND Corporation in Boston, and prior to that, he was the principal analyst at the Congressional Budget Office in Washington, D.C., where he co-developed the model used to analyze the CBO's analysis of the Affordable Care Act. So Dave will get us going on our presentation. He'll be followed by Dr. Karen Donelan, who is an associate professor of medicine at Harvard Medical School and Massachusetts General Hospital's Mongan Institute Health Policy Center. Karen is a survey researcher who has conducted hundreds of local, national, and international surveys of the experiences of patients and health professionals in various healthcare delivery systems. At the Mass General Hospital, Dr. Donelan leads a metrics project for workforce diversity, and she's evaluating population health programs to enhance care coordination and access for vulnerable patient populations. She is I'll leave it at there because I could keep on going and I really want to get into our webinar. So with that as an introduction, I'm going to turn the microphone over to Dave Auerbach. Dave, take it away.
Okay. Thanks, Pete. So I am going to start out by presenting some background and trends on spending and employment in the healthcare sector overall and focusing on the long-term care sector and thinking about care for frail elderly, and that will help lay the background and groundwork for Karen's talk, which is going to come next. And Karen will be advancing the slides for me, so let's go. Okay, so I'm dividing this section into two pieces. The first section is going to talk from the point of view of occupation. So we'll think about the different occupations such as registered nurses or LPNs that work in the long-term care sector. And then we'll switch to an industry perspective, looking at all of the different types of workers who work in the long-term care sector, whoever they may be. So we'll start out going occupation by occupation. And this is sort of a nice backgrounder to give you a sense of the healthcare workforce overall. This slide is depicting two things at once, really. It's showing each of the boxes is the different occupations that work in healthcare, and the size of the box is proportional to the number of workers in each job category. And we're also showing the average salary for each type of worker, and from top to bottom, the amount of education. And you can see that as towards the top, physicians are the highest earning group, and then you have your home health aides at the bottom, earning about 1/10 as much per year. This is kind of a good lay of the land. And on the next slide, Karen, you can see I'm kind of graying where most of the workers in the long-term care sector tend to fall, and you have a disproportionate amount among those home health aides, nursing aides, and there are some registered nurses, RNs, and some LPNs, a fair number of LPNs, mostly towards the bottom of this pyramid. Okay, that's great. The next slide is first starting with RNs. Roughly 10–15% of RNs do work in the long-term care sector, which you could think of as home health, nursing homes, or other areas caring for the elderly. Interesting trend going on to keep in mind in terms of supply of RNs is that there has been rapid entry into the profession lately. You can see going back to 1979, looking at the number of young RNs is a good indicator of entry into the profession. And this was dropping as the baby boomer generation transitioned into Generation X. We had about half as many young RNs in the workforce, and then since around 2000, that has really skyrocketed with the introduction of the millennials into the workforce. And we show that in a different way on the next slide, showing total workforce supply of RNs by generation. And so here we're showing, again, the same years. And you can see in the red is the baby boomers, and the number of baby boomer RNs over time peaked in around 2007 and has been declining as they retire. You can see Gen X in the green, and then you can see the millennials in the orange. You have, here we're showing actual data up until 2015, and then past that, there are the dots, which are projections from our forecast model. And you can see that the number of millennials RNs in the workforce is projected to be much higher than any previous generation before them, starting in around 2023. Excuse me. Okay, next slide. You can see that increase reflected in the number of people taking the NCLEX exam, which is the required exam to become licensed as an RN. And an interesting thing here on this slide is we're breaking this down by degree. There's two main routes to becoming an RN. You can have an associate's degree, which is a 2-year program, and those are represented in the purple curve, or a bachelor's, a 4-year degree typically, and those are in the blue. And if I had 2 more years, you would see this even more dramatically, that the number of associate degree RNs is now peaked and is starting to actually decline. And I think the number of baccalaureate prepared RNs has now surpassed those ADNs. And that's important because of what I'm going to show in the next slide. And I apologize, the legend here is a little bit hard to tell what's going on, but the orange are the associate's degree RNs. And what this graph is showing is by degree, the bachelor prepared RNs are in the red, the associate degrees are in the orange. What % of them work in hospitals or in the long-term care sector? And you can see that the bachelor's degree RNs in the red are pretty stable. About 70% work in hospitals and about 10% work in long-term care. Whereas among the associate degree prepared RNs in the orange, the % of them that work in the hospital has been dropping, and the % that work in the long-term care sector has increased from around 12% in 2003 to around 20%. So there seems to be a direct shift of those RNs, and it's not surprising. A lot of more and more hospitals are requiring a BSN for entry into some of some of their main staff jobs. And so some of these associate degree RNs seem to be finding their way into the long-term care sector. Okay. Now let's move to physicians. For example, not a lot of physicians work in the long-term care sector, but just as a general background, it's important to note that the supply of physicians has been growing very slowly. You can see that here compared to RNs in the red on top, and showing, I'll come back to PAs and NPs on the bottom, who have been growing more quickly, but you can't really tell on this graph. But the next slide will make the RNs and physician differences more clear. Showing since 1980. So how do we think about how much we would expect these supply of these providers to be increasing? Well, we can track spending on healthcare. Inflation-adjusted spending on healthcare per person has about tripled since 1980. And over the course of that time, the number of RNs per person has increased 82%, while the number of physicians per person has increased just 50%. And part of the reason for that, I get out of the next slide. There are additional barriers. I mean, partly it takes a long time to train a physician, but there are barriers and institutions that govern entry into that profession, mainly through residency, which is required to practice. Those residency positions are determined and allocated in a complex interplay between hospitals, who have to do the offering of the slots and training the residents, and the specialty societies themselves, such as orthopedic surgery, who has a hand in deciding how many of those residencies they're going to support and accredit. And they may have, in fact, have an interest in limiting those number of slots, which there's some evidence for. But there are other factors that play into that, such as patient volumes required for adequate training of residents, and hospitals' own financial interests, which might be in favor of or might be against having more residents, and so on. So a number of reasons why physician supply has grown slowly and is expected to continue to do so. And on the next slide, we'll see that filling that gap, in a sense, you have a rapid increase in the supply of physician assistants and advanced practice nurses, nurse midwives, nurse practitioners, nurse anesthetists. The training requirements are less. These providers earn less, not surprisingly. They have considerable overlap with the scope of what physicians tend to do. Various studies have found that quality is comparable, and the number of educational programs for NPs, for example, has grown 50% since the year 2000. So in the next slide, I'm showing the projections. First of all, from 2001 to 2016, these are depictions of the numbers of these three types of providers: physicians, NPs, and PAs, for example. In 2001, NPs and PAs made up a very small proportion relative to physicians. By 2016, you can see that they grew, still relatively small, but at the rates they're going, our workforce model projects that by the year 2030, these workforces will look quite different, with NPs and PAs combined approaching parity with the number of physician providers. Okay, now finally a note about the workers on the lower rung of that pyramid, for example, home health and other aides, many of whom work in the long-term care sector. And these are difficult jobs. They are low skill. Many of them earn minimum wage, and the industries that employ them find that, for example, from a study in Massachusetts, incredible amounts of turnover. A typical agency would have 16% of their workforce turnover in a given quarter. Agencies, the top problem they have is hiring and retaining folks. Low income jobs, many in households with below $20,000 per year, half of them on Medicaid in Massachusetts, about half born outside the US. So a lot of these jobs being filled by immigrants. Okay, so that's the end of the occupational perspective, and now shifting to who is employed in the long-term care sector and what do we know about them and what are some of the trends. Okay, I'm going to be showing data from several data sources. This one is showing trends in spending by category of spending for the entire country, data compiled by CMS. The thing to note here, you can see some interesting changes over time. Very noticeable is the percent spending in hospitals, which peaked at around 40% and has dropped to closer to 30-35 by now. You can see on the very bottom our long-term care sectors. Home health is in the black, which used to be negligible and now has, even though it's low, it has been growing and approaching nursing facilities, which had been around 5, 6, 7% and have slowly declined. And I think Karen might show some of this data that the nursing home population has been stable or even declining. Care is shifting in general out of facilities and more into the community, and that's the overall trend here. You can see that on the next slide as well. Oh, sorry, it's coming in a little bit. This slide is showing, yeah, no, that's good. Go to the one that, yep. Just an interesting feature of hospital spending versus home care spending is the difference in the variability. Here we just have spending per person with all the states lined up from top to bottom. And you see in the hospital sector, spending varies by a factor of about 2 to 1 for the highest spending state to the lowest spending state. That's in contrast to home health care spending, which varies from about 10 to 1 between Massachusetts and North Dakota per resident. So home care spending is being deployed to very different degrees across the states. Okay. We can look at growth in employment within different sectors in the long-term care overall, and you see a big increase in social assistance. It grew 12% between 2007 and 12 and accelerated to 18% growth in those types of positions between 2012 and 2017. Ambulatory care also growing rapidly, employment, and then you see that the hospital and the facility, nursing care, residential care are not growing nearly as fast. So following the theme of differences and variations, you can also see variation across the country, which is fairly striking. This graph is looking at employment in the long-term care sector in the four broad regions of the country. And interesting to notice is that, for example, if you look at the nursing facility section and the second to left there, in the Northeast, there are more than twice as many people employed in the nursing facility sector than there are in the West, almost 3 times. In home health, there are also a similar ratio of about 2 to 1. And in the residential care sector, by contrast, it's much more even across the country. And then in total employment in long-term care, you again see this about 2 to 1 ratio in the Northeast versus the West. It's that's a striking difference. Okay, next one. There are also some interesting changes over time. In the same vein as nursing home populations have been flat, nursing facility employment has been pretty flat from 2000 to 2015. Residential care employment has doubled, so that is a growing sector, and again, continuing the theme of care moving out of higher cost institutions into the community. The residential care sector, that includes assisted living or care for people with disabilities and things like that. Okay. This is a similar theme, but now we can break down the country into, instead of 4 regions, into 9 regions, and you see more variation. And here, focusing, for example, on 2 adjacent regions in the West North Central, which is your Minnesota, the Dakotas, Iowa, in the mountain region just to the west of that. Adjacent to each other, very big differences in employment in nursing facilities, for example, compared to the other sectors within the long-term care sector. Okay. There we go. There is similar types of variation, and looking at the distribution of who is working in long-term care. If you click on the next slide, I think you'll see my red circles. Okay, there you go. So interesting contrast between, for example, the Pacific and the New England division. You can see that in the Pacific area, no, this is the home health sector, you'll see about twice as many personal care aides employed as there would be nursing aides. And in New England, it's totally the reverse. These are occupations with similar levels of training, but some differences as well. And for various reasons that I don't entirely understand, these different parts of the country are just using different workers to do similar jobs. Okay. And there are differences as well in the residential care sector, not quite as stark as in home health, but you can see similar patterns. Big differences, for example, in the extent to which they use LPNs, licensed practice nurses, much higher in the East-South division. Okay. So what did we learn from that? I won't spend a lot of time, but we sort of went over some of the differences. In the West, there's a similar size workforce in home health, residential care, and in nursing facilities, whereas in the Midwest, you'll have twice as many people working in nursing facilities. Residential care has increased, nursing facility employment has stayed about the same, and you have definitely substitution by area between different types of occupations. Okay, just a couple more. There are also some interesting differences. Here we're looking at the long-term care workforce overall and focusing on those who are born in other countries and where people are coming from by occupation. Excuse me. It's well known, for example, that that we import a large number of registered nurses from the Philippines. You can see that in the light blue there in the RNs. There's also a pretty high proportion of RNs from Africa that work in long-term care, personal care assistants also. Personal care assistants, there's also a high proportion from Mexico and Central America. Okay, and on the last slide, I believe, looking at changes over time, you can see that in nursing facilities and in residential care, the proportion of workers from other countries has grown pretty much from all regions between 2000 and 2015. And this could be related to the difficulty in finding stable employment among some of the workers in these sectors. Okay, and that's all I had. I'll now, I think Pete is introducing Karen, or no, you can just take it away. Okay.
Go ahead, Karen. Thanks.
Okay. Hi, everybody, and thank you, Dave. I am going to take you through a little more focused look at people with training in geriatric and gerontology specialties within the professions. And I think what I want to apologize for a little bit, I'm a little under the weather, and if you hear me croak or stop talking, it doesn't mean I've died. It just means I have to take something to drink. So my apologies for being a little, quote, croaky today. Just because every presentation has to remind us of just how quickly the elderly population is growing, I just wanted to show you here the growth and projected growth in the number of folks in the U.S. who are over 65 in the blue and over 85 in that red line. And the this kind of doubling that's expected in the older adult population from 2005 to 2035 is why we're here today a little bit, and David's been showing you some of how the healthcare professions and industry have been trying to respond. A couple of other things that we note, which won't be a complete surprise to you folks, but really we have seen, and I've cut these by people 65 to 74 and people 75 and older, a bit of a drifting down of the proportion of people who experience a hospital stay in the course of a year in the US. And I think part of that has been, some payment and regulatory changes. There's also some evidence that, in terms of the health status of people, as life expectancy increases, people live longer. We've got some healthier folks. David showed you this kind of from the perspective of the workforce in home health care, but as care has shifted out of the hospital, we've seen the proportion of people in Medicare who use home health services go up. These data are from 2010, and I think actually have increased since then. But what I wanted to show you with this figure from the Kaiser Family Foundation is just that obviously as people have more chronic illness, more comorbidities, the likelihood of using home health visits rises. And obviously, as people struggle with activities of daily living and instrumental activities of daily living, you get up to much higher proportions. And I think that it sort of intuitively makes sense, but to think, that by the time people get to these ages and these states of health, their volume, their demand for services grows. I think, David, do you need to mute your phone? The nursing home population, though, has actually peaked. This is the number of people using nursing home services, and despite the growth in the population, the number's actually gone down some over the past decade, and that's that shift back into the home care sector that David was talking about. The group that has really grown tremendously are people served by hospice in these ages over 65, and there is, some of that is new benefits that were offered to support that, but really, I think a large-scale effort in the U.S. to make people aware of these options and to respond to care for people, in the later years of life in a humane and organized way. So a project that we are working on that's very generously funded by the Gordon and Betty Moore Foundation has been looking at trying to get a little deeper into this notion of where these workers who are caring for people who are over 65, where are they practicing? And you've seen in David's presentation some of the data around home health and nursing homes and residential care. We also have taken a look a little bit at who's working in primary care settings that serve people of all ages, who's working in primary care that's really focused on the more seriously ill folks who might be either at home and unable to leave home, or might be in a program like a PACE program, which essentially serves people who might otherwise be in a nursing home but who can remain in the community with some more intensive supports. We've looked at some senior health and geriatric practices. In our last installment of this series on frail elders, we talked in a focused way on care management, which has just grown tremendously. And then I think the other trend we're starting to see is toward more mobile health solutions, either for urgent care or diagnostic services, or more remote to reach people who can't get to the office. So lots going on in places where specialists can practice. I'm going to turn now to the implications of the workforce that we have, particularly in nursing, advanced practice nursing, and medicine for people who are gaining kind of additional training in geriatric specialties. For the nursing work, I'm indebted to Dr. Jennifer Kim and Dr. Linda Norman from Vanderbilt, who put some of these data together for a conference that we held last summer to discuss this issue of the workforce for aging populations. There has been a tremendous sort of series of changes in what's happened both for registered nurses and advanced practice nurses in the evolution of gerontology-focused nurses. The first division of geriatric nursing was established in the 1960s for the American Nurse Association. We started to change and increase certification, as has happened in many areas of nursing. through the 1970s, and that's actually the 1970s is where we first start to see nurse practitioners trained, increasing in standards for what gerontological nursing practice should look like. Big effort, Robert Wood Johnson Foundation for the Teaching Nursing Home programs, which really brought a lot of gerontology-focused nurses into nursing homes. We have in the 80s an organization of the sort of geriatric nursing and nurse practitioner associations and organizations. So the point here is just to show how, you know, continuously nursing is trying to respond to the demand that is starting to grow for care for older adults. A pretty important shift happened about a decade ago when nurse practitioners kind of underwent a major reorganization in licensure and certification. This came at the same time that the Institute of Medicine was looking at caring for geriatric populations. And at that point, there was a sense that geriatric-focused nursing and medicine would not be able to keep up with the demands of an aging population, and that it would be very important to start infusing primary care, both in nursing and medicine, with special competencies in the care of older adults, and to really try to buttress the skill level of people working in primary care to do geriatric care. Unfortunately, what that also meant was that there wasn't really a deliberate effort to create incentives for people to enter geriatric professions. And in fact, there was a part of the consensus model is that they created a certification for people to do to be adult NPs with a gerontology focus, and that actually cut it. So it enhanced the primary care aspect, but it cut the number of hours with a geriatric focus in that adult gero NP category. So I think with a recognition that, again, there had to be a response, we have now a new certification in the APRN gerontology spot, and this month they're launching a new certification for geriatric nurse practitioners who have a focus on complex and chronic illness, which I think is also an interesting outgrowth of how many nurses seem to be making their way into these care management, care transitions. So this is a rapidly changing profession, and I think we're likely to see more change as the demand increases. So RNs who focus in gerontology are really quite rare. It's less than 1% of the total workforce. The degree requirements for entry to practice as a gerontology RN, as they are for other nursing, can come even still with a diploma, an associate degree, or bachelor's degree. The American Nursing Credentialing Center does the certification here. The average number of years that an RN has experience in this field is 26. A third of them are working in long-term care. These folks have a unique set of skills around geriatric assessment, prevention of geriatric syndromes, geriatric sensitive patient advocacy, and creating individualized plans of care for older adults. So that's one small aspect of the workforce. We, in our travels and site visits to a number of different kinds of outpatient practices, very rarely saw gerontology specialized RNs, and that shouldn't be a surprise given how rare they are. But many of them are working in the home care, long-term care sector, and others are kind of sprinkled throughout different roles, I think in hospitals and outpatient practice. The gerontology advanced practice nurses are about, again, a very small proportion, 3% of all advanced practice nurses. These are master's prepared nurses, of course, and many of these folks are practicing in long-term care nursing home facilities, at least as of the most recently available data, which really come from the National Sample Survey of Nurse Practitioners. But they are there to do assessment, to manage the total medical and psychosocial needs of frail adults in nursing homes, to do, you know, medication management, coordinate teams, do the transition piece from hospital to short stay rehab or nursing home, and to be nurse leaders who educate other staff members. But again, this is a very small share of the advanced practice nurse workforce. This next slide shows for both the adult gero and acute care NPs for different types of NP specialties, who's really caring for older adults and where they're caring for them. And you can see that the biggest share is in the family and adult primary care specialties, and they're largely working in outpatient primary care settings. And then the other folks are sprinkled through long-term care and psychiatric facilities. In a fairly recent national sample survey, it looked to us 3 and 4 NPs were accepting new Medicare patients, that they are the predominant providers of Medicare beneficiaries with dementia, of people in residence-based care and long-term care. There is, as in other work, some data showing that clinical outcomes in case patients managed by NPs show fewer hospitalization, readmissions, especially among nursing home residents, and that nursing homes which employ NPs and PAs on their staff are associated with higher Medicare ratings. So it's been a particular challenge that there are relatively few gerontology nursing programs, and that they struggle to get faculty, which means that there's a limited number of mentors. NP practice restrictions in about half of the states in the US have an impact on where they can work and how independently they can work, which is true of other areas of NP practice as well. This ability to sort of fill available slots, there was a survey that we saw of several leading national universities that had NP slots in gerontology that that couldn't fill them. But we see the development of these new core competencies for nurse educators, some more core competencies that can be spread to all nurses. Much like medicine, nursing is trying to respond in those more generalist activities to give people more competence, and we're seeing those proceed. So I'm going to go quickly to the medicine side of the equation. I have several slides here, but there's a fairly similar story, and Dr. Sharda Mukunda, who's a geriatrician here at Mass General, helped me put these together. So clearly, we have a medical licensure, starts with the MD degree, but goes on to residency and fellowship, and geriatric specialties are require fellowship training beyond medicine or primary care training. For a comparative look, I wanted to show you sort of the active physicians in the US who are in family medicine, general practice, internal medicine versus geriatric. We add here palliative care, which has grown enough that it's actually surpassed geriatric medicine in these data from July of 2017. Neurology, obviously, also a very relevant specialty for older adults, and you can see their proportion here as well. Geriatrics has been around for about a century and was sort of first described as a unique specialty almost 100 years ago. Prior to Medicare, there were tremendous increases in elder poverty. The advent of Medicare obviously provided a basis of safety net and support for older adults, especially poor older adults. And we saw poverty among the elderly really plummet after the advent of Medicare. The first geriatrics fellowship is now about 50 years ago. So as I said, internal medicine, family practice, and then fellowship beyond, comprehensive assessment, facilitate goals of care, manage geriatric syndromes, prevent polypharmacy. These things, if it shouldn't surprise you, they look a lot like the competencies that we see for geriatric NPs and PAs. What has been a big disappointment, though, is those geriatric fellowship programs really are unfilled. So this is a program level where you can see that of 100 plus programs, the number of programs has actually gone up slightly, but the number of filled programs remains only about a quarter of the total, and a number of programs are unfilled, which is a big disappointment given the demand that we see. At the fellowship level, so these are positions, not programs, you see the same thing. With the offers have increased, but the filled positions have not. In fact, they fell off substantially from 2016 to 2017, and the number of unfilled positions has increased. Not surprising then, we see that there's a diminishing number of geriatricians in the U.S. One thing that's interesting here is that not only did we see the shift in sort of programs and unfilled programs, but even once people get in, the people completing those programs is actually in decline. And so it's even a little bit worse than we showed you in terms of just the diminishing number of people and the fill rates. This shows you a comparison then of that fill rate for geriatric medicine compared with what's happening with slots in family medicine, primary care, palliative medicine, and neurology, which by and large, all of which are filling, with geriatrics just really being significantly below the other specialties in terms of fill rate. So I came across a paper from 2016 by a group of folks who actually compared being a geriatrician with being a nurse practitioner in terms of lifetime earnings. And one of the interesting things is there have been a number of studies in the last couple of years which have looked at physician wage and salary by specialty. Geriatrics is so small that even when you do a national sample, a very large national sample of physicians, you rarely come up with enough geriatricians to sort of even give data to be reported out. So finding geriatric wages has been pretty tough. But the other point here is these folks basically said, okay, if you start at age 22 and you think about a career as a gerontology nurse practitioner versus a geriatrician, and you assume people come in with no debt and that all of their med and nursing school is financed, is it worth it to be a geriatrician, or should you just be an adult gero nurse practitioner? And interesting modeling here, but basically it takes to about age 40 for there to be a kind of break-even point in earnings. And using that time horizon, they do some adjustment. What would happen if we remitted all the loans for schools, and that will have some impact. The manual education mode would allow a shorter period of medical school and residency fellowship, and that would help too. But essentially, these authors conclude that you have to work a pretty long time in order to move beyond the break even. There are a lot of efforts to try to figure out what we're going to do, and I would recommend to you the Geriatric Workforce Enhancement Projects that HRSA is running in 4 states, and 44 organizations, 29 states, a major investment to try to help both the primary care and geriatric workforce kind of respond to the increasing demand. National League of Nursing is doing this Advancing Care Excellence for seniors within their training programs. We have an increasing number of new models like PACE and Hospital Elder Life, which are trying to respond to the particular needs of this population. And I think some new mechanisms of payment from CMS, which allow billing for annual wellness, chronic care management, home visits, advanced care planning, readmission, transitional care, all of which may allow some primary care and geriatric practices to get paid to care for this increasingly complex population. The other thing we're seeing is a lot of investment from the private sector in models of care for senior citizens and frail elders. And I won't go through these in detail, but basically there is a lot of it, private equity investment now trying to solve this problem of how do we organize the care for this big population that's coming. So tremendous demand ahead. We know that costs, especially late in life, are still continuing to increase, and there's a lot of effort to do that. Medicare managed care plans, Medicare ACOs, and the Medicare Advantage. We've shown you trends in both the licensed and unlicensed professionals, but it's pretty clear that the licensed professionals, specialists in geriatric care, are really not there, and we don't see them being produced in any large numbers anytime soon. And yet, it's assumed that primary care folks will pick up this, even though there's shortages in many areas of the country. These patients take a longer time to take care of, and so assuming that the primary care workforce can manage it is tough. We do see that growth in palliative care and hospice, and that's a different way of thinking about how to manage care at the end of life. Pressures to get these folks out of the hospital and into care at home and in assisted living continue. But I think at the end of the day, what we have to ask is how, when we need more nurses, we tend to pay nurses more and find ways of making, that workforce respond. And you've seen in Dave's data how much we were able to kind of shift the nursing workforce. And I think we need a sea change like that in geriatric care. We have to figure out how to build the incentives, financial or otherwise, for people to practice. People who do geriatric practice tend to be pretty satisfied in that practice, but there's yet this assumption that we just can't incent people to come in. Our traditional way of doing that is with money, and I'm sort of hoping that along with all these other enhancements, the additional potential for payment through these new payment mechanisms in Medicare, but also potentially, wage increases spurred on by the private sector may help. So I'm going to stop there and take your questions, which I'm sure are on your minds. And I also want to thank Pete, before I wrap up, for the opportunity to have had this series over the last few months on the care of frail older adults, and to the Gordon and Betty Moore Foundation that has provided funding for a lot of the work you've seen over the last few months in these webinars. Okay, Christy and Pete, back to you, I think.
Great. Thank you so much, Karen and Dave. Those were great presentations with a lot of data, so I'm sure they're going to generate a lot of questions. I would ask if you could try to keep your questions focused on the presentation today, and if you could try to word them as clearly as possible. I know it can be a little tough for presenters to ask questions or answer questions if they're not pretty focused. So if you'll take a moment and go over to your questions bar of your menu, and then you can log them there. Traditionally, I like to let Pete ask the first question. Pete, do you have a question for Karen or Dave, or should I go to the field? Or
yeah, I do have a question, but if you have others that are coming in, Christy, feel free to do that. But I do want to say to Dave and Karen, this was an extraordinary set of data. I've never seen anything this comprehensive and this deep. It's really a wonderful catch up and baseline for where we're at today. And I just wanted to say thank you. But Christy, go ahead if you have other questions. If not, I'll be happy to jump in.
Yeah, why don't you go ahead and lead us off here. I see some people working on some, but go ahead and lead us off.
Sure. So Karen, at the end, you talked about the incentives, and and I just wanted to know, are you seeing anything in policy or in the literature that would give us a better feel for the use of economic incentives, or is there something else that needs to happen in terms of a societal reassessment of what's important and where we want to see people choose professions in geriatrics to take care of so many people who are aging in our population? So I just want to know if you have any thoughts on that or seen some out of the box thinking.
I think the people that I've talked to about this, Pete, do see these new payment codes for chronic care management, for advanced care planning, for annual wellness visits within the GWEPS, the Geriatric Workforce Enhancement Program, trying to help primary care practices and geriatric practices get more of that revenue to perhaps pay for an extra nurse or extra hours of advanced practice nurse time, and bill for that separately has been one way people have talked about enhancing the billing. There's also a move kind of in another direction. There have been some proposals to do more with funding geriatric education, but I would say in general, it seemed to be the consensus of many that what we need to do is take all the workforce members we have and teach them better geriatric competencies, as opposed to just putting the money out there to try to pay people more in this field and do more. And that, but the fact that we're losing people and losing slots is very concerning. And the fact that most of the geriatric providers spend more time seeing these patients than primary care providers do means that they're sort of responding to the need of the older adult, but they don't. With primary care workforce shortages such as we have, I think this is tough. So we're hoping that in that growth in the PA and NP workforce, we will see more people come in here. But right now, most of that workforce is going more to nursing home than community. So we have a lot of challenges ahead, I think, to figure out how to do this better.
Thanks, Karen.
Okay, I have a question here. Dave, you mentioned in your presentation there's some variance in the occupation mix in home health. Do you think some of that's due to payer influence? Perhaps maybe they approve seeing one type of worker or another, or could that be to policies at the state level?
That's a good question. Actually, there was one slide that I didn't end up using. I took out, but it does directly get at that, and it did suggest that I was able to find average earnings for home health workers in the states, and that seemed to correlate with the distributions of workers that states were using in the long-term care. So it seemed to be related. That and what kinds of policies do affect those costs, those earnings? Definitely. A lot of home health is funded through Medicaid, and Medicaid is a state program. Those payment rates are under their control. And even more than that, for example, you might have noticed Massachusetts was the single highest state in home health spending per resident. And it's exploded lately. And the state has in the past couple of years has sort of tried to crack down on that in terms of tightening the rules for who can get such services, and I think restricting the agencies themselves and some of their activities, and that definitely has ripple effects all across the industry and the professions that work in home health. So yeah, definitely state policies impact that sort of variation that you see.
Okay, great. I have one more question here. I noticed that we really increased the nursing workforce in the past decade. What did we do? I think that's a collective we. What did we do to make that happen?
Mm-hmm. That's a good question too, and maybe Pete, you can follow up after I give some of the reasons, at least that we know of. I mean, right? What did we collectively do? There's a number of interventions that once it started to become known that it looked like we were facing nursing shortages in like the late 90s and early 2000s. A number of actors attempted to address this. There were private foundations such as the Johnson & Johnson campaign that launched a campaign for nursing's future and spent a lot of money on a number of levels and fronts that Pete could talk about, including advertising campaigns and local events to increase interest in nursing. There was some federal government activity with grants and scholarships towards nursing schools. The schools themselves instituted some innovations in accelerated programs to become an RN, such as shifting from other fields into nursing, and made it easier pathways to do that. Some of what happened was probably just sort of a natural consequence of things going in the broader economy, such as a movement away from manufacturing jobs and that just making the nursing profession look relatively more attractive, and where other folks might have gone into other fields. Now it was nursing was right there, available, and pretty guaranteed employment. Do you want to add anything to that, Pete?
Dave, I think you covered it a lot. I think a couple other thoughts. The states, about 35 nursing workforce commissions and groups were established in the states, and there were a number of other corporations that came together to sort of pull attention and resources into nursing. And the one thing I think that is really satisfying about all that is they seem to work. Because of the influx of people coming into nursing, we now project that we should be able to replace all of the retiring baby boom RNs, and that was about 1 million of them. And they will go out of the workforce by 2030. We expect we'll be able to replace them all. Many will come into nursing in the millennial generation, but that is a positive story that we can talk about today, which is potentially helpful for the other issues that we were discussing with regard to geriatrics. I'll stop there.
Great. We're approaching the top of the hour here, but I have one more question I think maybe we could ask in the next minute or so and get an answer. What impact, if any, do you expect to see in states that have enacted minimum wage laws on the home health and nursing home workforce?
I could take a quick shot at that. This is David. I wish I knew a little more about this, but I know that it's been an issue here in Massachusetts where I'm not sure how much this was a consequence of the minimum wage, but there was also, I believe, something like an hours restriction placed on home health care aides, where I think it couldn't be more than a maximum of some number of hours, and they're provisions that are sort of attempts to improve the quality of life of workers in these professions, but at the same time there were some complaints from those who rely on those services, and that it was now harder for them to get the kind of care they were used to. So it seems like, you know, as in a lot of things, there's no perfect answer, or there's trade-offs involved. I don't know if somebody else has a thought about that, but you know, it's a difficult one.
Yeah, I mean, this is Karen. I think one of the things that we can't do with something like that is sort of keep our blinders on. You know, David's data showed how many of these folks are on public assistance, and you know, they Medicaid, potentially, you know, food stamps, other forms of assistance, because we're not keeping the wage at, you know, at a living wage for people. I think we also have to be realistic that changes in immigration policy, especially in certain parts of the country, could really have an impact on this workforce. And if it's largely an immigrant workforce, and we make it harder for immigrants to do work like this, then in order to attract other people into those roles, we might have to pay more. And so I think we have to think of it more holistically, as, you know, we all think of what bucket the payment is coming out of, but I think we're paying one way or another. And the question is, what's the most rational way to get people earning a wage that allows them to work in the economy and do this kind of work that we need? And I would say the same thing in nursing. You know, we know there are lower wage nurses who are doing a lot of the work in nursing home and residential care. You know, we have to decide what we value, but given the number of people who are going to need these services, you know, that will cost a lot of money. So we have to decide what we're going to do.
Great. We are out of time. I know we have so many other questions we didn't get to, and I apologize for that. I always am surprised by how quickly time passes with these events. So in conclusion, just to say thank you so much to our presenters, Dave and Karen. Thank you so much for all of the help with organizing this series as well, Karen. And that will conclude our webinar series on the workforce serving frail elderly adults. And so we invite you to visit our video library tab on our website for any of the other webinars you might have missed. And we hope to have you attend our future events. Thank you very much, everyone. Have a great day.
Thank you.
Thanks, Christy.
Thanks, Christy.